Hi, I'm Lynn Paltrow. I'm the founder and executive director of National Advocates for Pregnant Women, and I'm so honored to be here. So honored to have Dr. Orisha Bowers start us off with a beautiful call, a beautiful song. And I'm so honored to be here with two leaders and activists, Dr. Bowers, Orisha Bowers, and Louise Vincent, who I have also had the privilege of working with in a number of contexts. By way of introduction, I am a white cisgender woman. I am Jewish, and I understand that means I will not be replacing other white people. And I'm so old that I still call myself a lesbian, even though my daughter says that I should identify as queer. I'm the founder and executive director of National Advocates for Pregnant Women. And our whole purpose is to address and celebrate and build on intersections, to recognize and put back together many, many things that have been separated. So, for example, the same people who have abortions also have babies. And they all need to be assured that they won't go to jail and won't be in any way subject to state punitive action because they got pregnant, because of the outcome of their pregnancies, because they lived their lives as human beings during pregnancy. Much of the work that my organization does, it's all integrated in terms of legal advocacy, organizing, and education. But a lot of our core work is pro bono criminal defense for people who've been arrested in relationship to their pregnancies. So I want to start by sharing a few slides. First of all, here you can see all three of the speakers. Dr. Bowers will be next, and then Ms. Vincent. And this was a panel that used the term criminalization. What does that mean? It means the use of criminal laws and law enforcement to respond to a particular issue or problem. And NAPW has been the organization that not only has been representing people arrested, women arrested in relationship to their pregnancies and pregnancy outcomes, but we've also done the documentation. Where is it happening? Why is it happening? And working with people to stop it from happening. So people have been arrested for being pregnant and we say it that way because a lot of times people say she was punished for her conduct during pregnancy. But the fact is, the person wouldn't have been punished but for the pregnancy. So pregnancy is part of what is getting criminalized. So being pregnant and having an abortion, contemplating having an abortion, not having an abortion, falling down a flight of stairs, being in a dangerous location, being HIV positive, seeking help and admitting to past alcohol use, losing all hope and attempting suicide, as Bebe Shui did, experiencing a miscarriage, stillbirth, or the loss of a newborn, allowing oneself to be injured, shot while pregnant, the Marche Joan case, rejecting or delaying cesarean surgery, going to term and giving birth, girth, well, I'll fix that next time, having a home birth, using or being dependent on alcohol or a criminalized substance. What's interesting is that, so we did a study to document arrests because basically people didn't believe they were happening. And we published this in the Journal of Health, Politics, Policy, and Law. And it looked at every case we could document in which pregnancy was an element of the crime or the deprivation, the arrest wouldn't have happened but for pregnancy. And virtually all of the 413 cases we identified in 44 states were were cases in which the arrest wouldn't have happened but for pregnancy. And we use the concept of liberty arrest because in the law world, people criticize Roe v. Wade, which you've probably heard is hanging in the balance in the Supreme Court with Amy Coney Barrett, who was appointed recently. The argument is that decision was based on a right to privacy. Privacy doesn't appear anywhere in the Constitution, but the word liberty does. And if you lock somebody up, or you hold them down to force them to undergo surgery, or you detain them in a mental hospital or a so-called treatment program, those are all explicit deprivations of liberty. And so that's what we looked for and what we found during those years. The picture on the right is a map, and the darkest color is where the most arrests happen. So it won't surprise you that more arrests occurred in the South than in other parts of the country. But there is virtually no state where these arrests haven't happened, and that includes New York and California and elsewhere. I should say that in addition to my other identities, I am, of the three of us, I am not from the South. But I remind you that there are places in every state that are red states, that are profoundly conservative, hold certain political views, and in the case of where I grew up and to this day, are segregated by race. So I grew up in Massapequa, New York, and there are places even in California, like Hanford County, that we'll be talking about, where these arrests happen. Our study also found that 72% of the targets for arrests that we could identify were low income, 59% were women of color, and 52% are African American. So the racism that we see in the criminal law system overall is very much present in these cases as well. And very sadly, we also, when we could figure out how the information got to the police, if it came from healthcare providers, those healthcare providers were more likely to report their Black and of color patients. So looking at these cases, well, first of all, let me just go back and say, so we're looking at cases now from 2005 forward, and the frightening part, one of the many frightening parts, is that the arrests are probably since the period of 73 to 2005. In the much shorter period between 2005 and now, we are seeing more than double the arrests. And that is the result of mass criminalization leading to mass incarceration that captures pregnancy and its outcomes, including abortion. One of the things that's really important and leads to my colleagues' talks is that although the cases are not exclusively, the arrests are not exclusively about pregnant people and drug use, 84% of the cases are. So 16% aren't, and those are falling down the stairs, home birth, refusing cesarean surgery, for a whole range of reasons that prove that it's never going to stay limited. But what we've come to understand is that the path to arrests of any pregnant person, and especially the path to arrest for having an abortion, particularly a self-managed one, is being laid by the cases involving pregnant women and drug use. And this goes back to the 1990s with the crack baby myth, when stories about particularly Black women caring so little about their children that they used this drug that absolutely everybody knew caused damage. They went ahead, they had their babies. Now, all of that harks back to slavery, to the idea that Black women don't care about their children. And so then it's okay to separate them from their children. It is okay to enslave their children. It is okay to describe them as people who don't care. And the material, thousands of articles appeared, like this one in New York in Time magazine, and this is, I think, from 1991. Their mothers use drugs, and now it's the children who suffer. Can the innocent legacies be rescued? If you have somebody who's innocent, you have to have somebody who's guilty. And then when you get to the story itself, that's sort of described as written for a white middle-class audience, saying these kids are going to come to your schools and take away resources, you see that the skin color gets darker. So the entire crack baby myth, the entire premise upon which women can be arrested in relationship to their pregnancy outcomes is based on racist portrayals of particularly Black mothers. And you see it again here, the same year, Rolling Stone. These babies are like no others. They're brain damaged and so forth. The message in all of this from that time is this article, Crack Babies, the worst threat is mom herself. And it's just brilliant, right? If your view is that your government has no responsibility for taking care of the general welfare, of ensuring that people can have safe lives and enough to eat and adequate income. If you want to make sure that people feel that everything is their own fault or somebody else's individual thought, then you tell these narratives. And they're the same narratives whether you're talking about drugs or you're talking about abortion. So if you look at the article on the left, and then you look at this billboard that was put in particularly Black neighborhoods, that was about abortion. The most dangerous place for an African American is in the womb. Black women leaders protested these, got them taken down, but the message in each is the same: hold individuals accountable, punish them, direct your rage at them instead of identifying where it is that our systems fail us and what our collective action could do. Just to be clear, for any of you who have not had access to this information, it has been admitted over and over, never enough, that everything that was written claiming that prenatal exposure to cocaine was uniquely, inevitably harming was false. The New York Times did an apology in 2019, 1819, called Slandering the Unborn. The author of this particular one won a Pulitzer that year. And there's this wonderful document, this short piece that really takes you through not only the myth of the crack baby, but also up through opioids. We are living in a time in which there is massive science denial. That did not start with COVID, and it is certainly an essential part of the work that all three of us on this panel do, the science denying, the willingness to repeat lies over and over. So as I said, what we've been seeing since 2005 is an increasing rate of arrests, more and more people being arrested based on pregnancy. These are some slides that my colleague Deborah Small found. We look at the increasing rates of incarceration despite so much good work. And the fastest actual growing group of people, it remains disproportionate to Black women and women of color, but the fastest growing segment of people being arrested are white women in Tennessee. And within the context of arrests around pregnancy and drug use, that is also true. A brilliant paper by Kiara Bridges looks at this and says, well, what happens? Is there white privilege if rural poor white women are being arrested? And her answer is no. But when you start a response to a problem on the backs of building on racism, that approach, criminalization rather than healthcare, rather than supporting communities, will inevitably affect everybody. It's what is used to set the tone, to set the law, and to create the arguments. We should know that only 3 states today actually authorize arrests of women in relationship to their pregnancies. And those states are Alabama, South Carolina, and most recently, Oklahoma. And it's not because any legislature actually said you can do this. It's because radical activist state Supreme Courts made up these laws. And every time there's a new arrest, it's a prosecutor hoping the courts will do the same in their state. Tennessee, which you'll get to hear about from Dr. Bowers, is the only state that has actually had a law that the legislature passed authorizing arrests in relationship to pregnancy. And as you'll hear, that law came into effect in 2014 and went out of effect because of amazing work being done in 2016. Some current cases. Chelsea Becker is in jail in California for having experienced a stillbirth that is blamed without scientific basis on her drug use. She is currently being held in jail in the Kings County Jail on $2 million bail. It had been at $5 million. Our efforts to get it reduced got it to $2 million. The argument the prosecutor used and the court accepted is she poses an unreasonable risk to victims in the community. How? Why? Because she might get pregnant again. This is the same argument that justified sterilization of women in California jails that is beautifully documented by a new documentary called Belly of the Beast. In California, another woman, Adora Perez, who did not know that she was being charged with a crime that does not exist, pled guilty to, rather than murder, to manslaughter. And we are also working with her attorneys to free her. She's pled guilty to manslaughter, where she is serving 11 years in jail. Now, I just want to go back to bail. And since we're talking about criminalization and dehumanization, bail is a very, as you probably heard, unjust system. So I want to compare it to two recent instances where people have been able to get bail. The ex-officer charged in George Floyd's death, his bail was set at $1 million. He didn't experience a stillbirth, a natural outcome of pregnancy. 15 to 20% of people who get pregnant experience miscarriages and stillbirths. We know what that police officer did, the murder documented on film that he did. His bail was set at only $1 million, and he was able to pay that. And Kyle Rittenhouse, who shot and killed two people and another at the protests responding to yet another murder of someone by Jacob Blake by the police, he was released on $2 million bail, with apparently all of these groups and people coming together to pay his bail, none of which has happened for most of the women who've been arrested in relationship to pregnancy and drug use in particular. And a great example of what activism can do, Latice Fisher in Mississippi was arrested when she had a stillbirth at home. There was no claim of drug use, but it was claimed at first that, in fact, it was a live birth. She hadn't taken care of the baby. That was not true. And they were relying on some research she had done about misoprostol and mifepristone, the medications that work to end a pregnancy safely, no evidence that she used it. And I'm very happy to say that Color of Change and Lori Bertram Roberts with the Mississippi Freedom Fund worked to get bail for her, and she was released. And working together, we were able to get the charges finally dropped. But it was one of the rare cases. The only other case like that is the case of Marsha Jones in Alabama, who was arrested for manslaughter for getting herself shot while she was pregnant. And again, there was an outpouring of support for her. But I just want to point out that neither of those cases included an allegation of drug use. Regina McKnight is a woman in South Carolina who experienced a stillbirth. She was charged with homicide by child abuse and convicted of murder for experiencing a stillbirth. We knew at the beginning, we knew 8 years later, when we finally were able to help get her out on post-conviction relief, cocaine does not cause stillbirths. And although the holding in that case was, if you do something intentionally or unintentionally that causes the death of your fetus, you can go to jail as a murderer. We could not ignite national outrage about her case. I hope that wouldn't be true today. As Ms. Patricia Williams and Lori Griffin behind her, who were plaintiffs in Ferguson v. City of Charleston, they challenged the South Carolina Medical University Hospital's policy of secretly searching primarily their Black pregnant patients for evidence of drug use and turning it over to the police. Here they are protesting in front of the Supreme Court. Pregnancy is not a crime. Addiction is not a crime. And using drug tests as a guise for searching pregnant patients for evidence of a crime is not constitutional, thanks to their courage and willingness to be plaintiffs in that case that took at least a decade. I want to point out the connection too. Many of you, I hope, have been part of the protests against the murder of Breonna Taylor. That that murder occurred as a result of no-knock warrants. No-knock warrants were allowed based on the claim that drugs are so terrible, including marijuana, are so terrible, we should be able to break into people's houses, looking as the people on the right look, to find evidence of drugs that make people feel better. I want to say that our connection, meaning if reproductive justice is the all brilliant, visionary connecting concept, then those who care about reproductive health, rights, reproductive justice have to be working together to end the war on drugs that allows for no-knock warrants, and to say that given where we think that Roe is going, given the number of arrests that have already occurred for self-abortion, if no-knock warrants can be used to break down people's doors, to go into their houses to kill them because there's a belief that marijuana is in the house, what do we think will happen if abortion is outlawed and police believe that misoprostol and mifepristone are in your house? This is what I hope we together, through our criminal defense work, our activism, our alliances, and the collaborations that we've done, will help prevent from happening. The last points just have to do with, it is not, when we talk about criminalization and dehumanization, it's not just the criminal law system, it is also the child welfare system. If you want to destroy communities, you can put the men in jail and put the women under the control and surveillance of the child welfare system. The new organization, Movement for Family Power, is working on that directly. They've published this beautiful paper, how the foster system has become ground zero for the US drug war. The so-called child welfare system works almost identically to the criminal law system in terms of who they target, overwhelmingly Black and brown families, how they destroy communities, how they take resources out of those communities. And we need to be working across movements to challenge and defund not only the police, but also the punitive and counterproductive child welfare system. Arisha, I'm going to turn this over to you. Thank you.
Good morning, everyone. I'm Dr. Orisha Bowers. I'm currently the Regional Director for Harm Reduction Coalition, and I oversee the HEP Connect initiative, which is an initiative designed to expand syringe service access and harm reduction in the states of Tennessee, Kentucky, West Virginia, Indiana, and North Carolina. The research that I will talk to you about today was conducted when I was employed at Sister Reach, which is a reproductive justice organization located in Memphis, Tennessee. The fetal assault law, as Lynn recently stated, was enacted in 2014. The fetal assault law was in effect from 2014 to 2016, and as Lynn stated, this law allowed pregnant women who use drugs to be incarcerated, facing a penalty of up to 15 years in prison and loss of custody of their children. Sister Reach, a reproductive justice organization located in Memphis, Tennessee, along with opponents of the fetal assault legislation, rallied an unprecedented amount of attention nationally, internationally, and locally against the criminalization of pregnant women. And this law sunset in 2016. In 2017, we launched, and we meaning Sister Reach, and launched a qualitative research study, which was led by myself in partnership with NAPW and IBIS Research. We launched a qualitative research study that documented the experiences of women arrested and charged with fetal assault. We know that over 124 women were arrested statewide in the state of Tennessee during the enactment of the fetal assault law, and we spoke to 41 of those women. What we found was that all of the things that Sister Reach and other advocates predicted, as well as other things, were uncovered as a result of the research. This included things like women avoiding prenatal care, which was predicted was in the early days when this law was proposed, that women would avoid prenatal care in order to avoid arrest. And this was proven when we spoke to women who were charged. Many of them did not seek prenatal care, or when they were asked certain questions during their visits, they started to skip their visits. We also found that many of these folks were coerced into drug court or coerced into the use of birth control methods that they would not have chosen had they been given all of the information that was available about their options concerning birth control options. Many women lost custody of their children and to date have not been able to regain custody due to difficulties navigating the legal system, due to the inability to obtain employment and stable housing, which were all items that they had to be able to do in order to regain custody. Many of them also suffered all of the barriers that comes along with being convicted of a felony crime. Many of them, again, were unable to obtain stable housing and stable employment. What this law did not do was accomplish the goals that were stated in its enactment, which were to reduce opioid usage during pregnancy, and it did not lower the number of neonatal abstinence syndrome cases that we saw in the state of Tennessee. So the law was a failure. And what we learned because of this research, where we asked women who were charged with fetal assault what led to their drug use, what were things that happened in their childhood and their early years of their life, their family history, what were the things that they needed, what would have made it easier for them to cope in their lives or get through situations in their lives, what resources would have helped them. They gave us information and recommendations about ways in which other women can avoid situations that lead to drug use. And we took all of those recommendations and put them in a report that was put out in 2017. We also were able to defeat an attempt to reintroduce this law in 2018. Um, because again, this law was unsuccessful and we could have avoided these changes in these women's lives and these traumatic changes in their children's lives had we just listened to people with lived experience, had we just asked the question about what was needed instead of assuming that locking people up was the solution. With that, I will turn it over to my counterpart, Louise.
Hello, my name is Louise Vincent, and I have been working with Urban Survivors Union and North Carolina Survivors Union for a number of years. We are a drug user union, and that means we work with people who use drugs, women who use drugs, pregnant and parenting people who use drugs, and we really believe we are the drug user voice. So we're a community-led group whose aim really is to build power among people who use drugs and help people see the realities of substance use and substance use disorder, as opposed to a lot of the media hype and um, and harm done to people who use drugs based on um, based on misinformation. So I want to specifically talk about House Bill 918 first. This was a bill that was introduced in North Carolina, and it had three sort of core pieces. If your newborn baby was found to have been exposed to the drug in utero, your child could be immediately removed from your custody and home. They would be out of the home while the case was proceeding. Um, and once your child is taken away, the court could decide, because your child was exposed to drugs in your utero, the state didn't have to make any effort at reunification. And this is particularly difficult because if you don't have anyone helping you pay for these services and take care of these services, it can be very difficult to do this on your own. And if your child is with the same foster parent for 15 months, no matter what the reunification plan, that foster parent would have the right to petition for custody. So all of these things made it easier to take children away from people perceived as people who use drugs and people who are perceived to not deserve to have their children. What we know is that drug use is not incompatible with parenthood, and it doesn't define how much people care for their children. I am a woman who has struggled with substance use disorder my entire life, and yet have been very involved in the raising of my children and been very involved in having my children with me, and have been able to make decisions in the best interest of my children, um, regardless of my substance use. And we really need to understand that, you know, we place these barriers for people that use drugs, and we make it impossible for them to reunify with their children. And I see it every day, all day long. Um, a drug test isn't a parenting test, right? And that's one of the things we really need to, we cannot tell anything by a drug test. A drug test gives us an idea of when a parent has used, or when a person has used drugs between a certain span of time, and they can be wrong, right? So not only are they not accurate all the time, it doesn't give us any indication of what's going on in a person's life. I mean, period. Um, and this is one of the most harmful things that I've seen, is this reliance on drug testing to tell us about people or tell us what's going on with people. Um, eh, I've often heard people say, well, if you love your children, you would stop using, you would not do those things. We also need to understand that love is not a cure for substance use disorder, right? So there's a lot of things going on, and and we watched as the people who were tasked with supporting pregnant and parenting women who use drugs really couldn't do it. When this bill was when we first saw this bill introduced, there was really very little support. We would go on calls and we would hear people say, well, this is a complicated issue, this is really difficult, because you hear drug use and parenting, and boy, that ignites people's I mean, people really don't know how to cope with this stuff. We have not talked about these issues enough, and what we've heard about these issues has been inaccurate. you know um, we were just listening to the myths of the crack baby era, but so many people didn't didn't get the updated version and find out that none of that was true. We still hear people talk about addicted babies, and a baby cannot be addicted. We still hear this sort of language, and we hear misinformation about what's good for children and babies all the time. There was just an article here recently. It was children crying for heroin instead of their mother's milk. I mean, it was just as difficult to read as many of the articles in the 80s about crack babies. But so North Carolina Survivors Union really got involved. We tried to form a coalition. We developed a sign-on letter, and we started really trying to inform people about what it was to be a person who uses drugs and to be a parent. Um, there was an amazing coalition formed in a very short amount of time, really unlike I've ever seen. And I really believe, had we not gotten involved, this bill would have passed. And what we know is that people who are using drugs and pregnant are not going to go and get prenatal care if if they fear having their children taken away. And what we also know is that people need to be able to get on medication assisted treatment, which is still criminalized. So it is still really difficult for someone to get on methadone or buprenorphine and not be, you are immediately um, uh, tasked with CPS the minute you get on these drugs, which is really unfortunate, because what we know is if a mother is not in withdrawal, then the risk of abuse is reduced, or neglect is reduced by exponentially. Um, so what happened is the bill passed, and then we had, we used our letters, we used every group that we could get with to sign on to this letter. We sent letters to the governor asking him to veto the bill, postcards. We sent letters from children of parents who use drugs. We sent letters from parents who use drugs. Um, and the bill was vetoed. And so we were very, very grateful that this happened, because 2 lives are really ruined when children are sent to foster care. What we know is that foster care isn't producing great outcomes, and 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 when you take a child away from a parent, that doesn't do great things for her either. We know that there is treatment available, although treatment isn't the only option. And there needs to be more treatment available, and evidence-based treatment that actually makes a difference in people's lives. There's so much treatment that is not useful, and it's non-evidence-based treatment that we really need to look at that. And what we know is that the people that are most affected by these laws are Black and brown women and poor women. Um, we know that these are systems of surveillance. These are not systems of support. You cannot have supportive systems when at the end of the day, um, they have the power to remove your child. You can't be honest in a system like this. You cannot talk to a person and really get the help you need when there is so much punitive, um, there's so much ability for harm to come. So when we talk to women and talk to them about what would actually be helpful, what we hear is what would be helpful is to real systems of support that do not involve removal of children and permanent removal of children. Um, we have the power. I mean, we do have the power to reimagine family safety and well-being, and we need to. Our families need support, not separation, and certainly not surveillance. If you surveil any family, you are going to see things that aren't perfect. We are doing a work in a narco-feminism story sharing project at North Carolina Survivors Union right now, where we're examining what families look like, and what it is to be in a family where someone's using drugs or someone's not using drugs, right? And what we're seeing is that, when you take a look at families, there's no perfect families, and there's no perfect systems. And um and the more you look at them and the more you surveil any family, the more problems you're going to see. We have got to dismantle and divest from systems that cause harm by separating mothers from their children, and feed cycles of incarceration. um, the drug war is linked to these systems of separation. Um, and we have got to see the drug war as a problem, and drug policy as being, as part of this problem. We are destroying families. We are separating families. We are, I've watched so many people be be harmed in such ways by having their children removed that they are unable to pick their lives back up and put them back together again. these sorts of harms um, don't go away. You don't recover from losing children easily. And what they do to the fabric of families is just truly, truly difficult. I mean, we really need to see family as the most important structure. What's good for the mother is good for the baby. Our communities need better social support systems such as food, housing, living wages, jobs. Um, you know, if we could actually support people who use substances and parents who use substances, maybe they could get the support they needed rather than the judgment and stigma and the and the and the very negative consequences. Drug policy actually creates harm. We talk about, do you have a drug problem or a drug policy problem? And policy actually and criminalization actually creates more harm than many of these drugs create. And if we had good systems of support, and if we had, methadone and buprenorphine and safe supply and many of the, programs that would truly be supportive for families, um, then I don't think we would see the harm that we see. I mean, I think it's really important to say that, just because someone uses drugs, this does not mean they are harming or abusing children. I mean, that is not a definition for neglect and abuse. And we really need to understand that. And I think because of media and because of the way we have framed substance use, we really struggle to make those separations. We also are unable to make the separation of substance use disorder and drug use. I mean, there are many people that use drugs and don't have substance use disorder. And we cannot afford to do that, just as we cannot afford to conflate substance use with neglect, mistreatment, or abuse. There's a growing body of literature that does not find that drug use correlated with child maltreatment. Substance use does not define how much people care for their children or their ability to parent. And this is simply, this is the science of it. There's just nothing more hurtful than taking a baby away from someone and saying to them they aren't good enough. We have got to enact policies that go beyond masking harm to get to the root of it. The system does not have to, at this point, the system does not meaningfully address harm. It simply punishes it. And we can do better. And in North Carolina Survivors Union, we really believe that we must do better. And we believe that we must include pregnant and parenting people in these discussions. We are, we are leaving pregnant and parenting people out of the discussions and out of the solutions. And we are just seeing them as bad people who deserve to lose their children, or people that don't love their children. Ending the threat of criminalization for drug use will inspire more trust in the healthcare system. More people would access prenatal care. All of these things benefit children. We need to work to create new systems that really address the challenges and the realities that we're facing in this world. Better access to community-based care and support would help mitigate harms. Like, all of this stuff is about reimagining a system that does not see removal of children and permanent removal of children as a solution, and one that is able to understand how the criminalization of drugs has created its very own set of harm. As we criminalize more people and criminalize more parents, and more parents are put in prison, these are parents that are missing from homes, that are not able to raise children and not able to be there and not able to be connected to their children. And when you create this disconnection, you are really destroying the fabric of families. And I think with that, I will move back on to Lynn.
Thank you. So many profound and important things. Wait, there we go. I'd love, I'm not sure how much time we have left, but I hope Arisha will, bring her face back on. I guess I have first, I have questions for both of you. And I know I promised to start off, and we also have, there is an actual Q&A in the box, but let me, one for each of you. Louise, could you just explain the term narcofeminism? Oh, you're muted.
Sorry. So narcofeminism is our women who use drugs story sharing group. So it is simply a way of talking about, it's a group of women around the world really that are engaging in story sharing and narrative disruption around substance use and drug use. And we are women who use drugs and are creating these stories and putting our stories in the world, the stories we've never told, the stories, especially the stories of pregnant and parenting women. I never thought, when I started doing this work and we started doing work in reproductive justice and we started sharing the stories of being drug using mothers, I didn't realize how hard that would be. I didn't realize how these were the stories that I'd never heard. I've never heard these stories told. And so it becomes very difficult to tell them because you are the first people telling the stories and sharing your truth. And we know that this group of people is stigmatized and demonized. But yet there's such freedom in telling our stories and really sharing the truth of these narratives. What we found is so much implicit bias, so much, by sharing these stories, I've really, in my own world, as I tell these stories that I thought made me such a bad mother, what I came to see was systemic problems, not individual level, not that I was somehow inherently bad, that the system is somehow inherently broken. And the more I'm able to see that, the more I'm able to forgive myself for my own, the things that I've done in my life that I feel bad about, and that enables me to heal. And that's what we want. So narcofeminism is about healing, I hope. It's about reimagining what a drug using person looks like and seeing the structural reasons that drug use is connected to crime and all of these things.
So Dr. Bowers, I kind of have a two-part question. So the first is, you may have been doing harm reduction work before you did the phenomenal research you did for Sister Reach, with us, whatever. But you now are focused, you're working for the Harm Reduction Coalition. And I'm just wondering if looking back on that research or what you learned from it, there's anything you would do differently or might have asked, or, do you have a new perspective from focusing now on harm reduction?
Certainly. I think the thing that I did well was creating safe environments for women in Tennessee who had been charged with fetal assault to feel comfortable talking with me. As Louise pointed out so beautifully, these are very painful stories for people, and they're ever present, right? They aren't just something that you just recall and tell. And so I think that's the thing that I did right, the thing that I hope to do differently, because this doesn't go away. I'm just touching the same issue in a different place, but really looking at ways to try to deal with policies that create harmful environments is what I would choose to focus on going forward. Is really trying to get legislators to hear these stories from women, to think of new ways to draft and craft policy that isn't so punitive, that helps to create resources, right? One of the big things that we found in the research was that access, people thought that there were services available. And what we found was that services were really not available to this community of folks. You know, yes, there are treatment facilities, and all this money was put into creating treatment facilities. However, they were not built and located in the areas where the women were. And then even with the services that were available, it was such a small number of beds available to people who were pregnant. So, you know, this idea that services are out there, all you have to do is reach out and grab services. For me, I think the thing to do differently is to figure out more innovative ways to make services available to the people who need them and make them accessible to people for real, like affordable to them. Because we know we don't have people in Tennessee, we have a lot of people in Tennessee who don't have access to insurance. So, like, just kind of really working to tear down barriers, policies, and practice wise that keep and lock people out of access and services. Because, like you both already mentioned, this is not, we're not talking about people who don't care about themselves or don't care about their lives or don't care about their children. Um, but you can't access something that's not real.
Right, right. So I have many other questions, but I see there too from the audience. One is from Paulina. Are there any contradictions between misoprostol, mifeprex, and other drugs? And I'm not sure any of us are an expert on that. I will say that I don't know of any counterindications, if you mean with any of the arbitrarily criminalized controlled substances. I also know that abortion providers are also people who've just heard all the stigma and misinformation and get very nervous and tell people to stop taking their methadone, which is the gold standard treatment for opioid dependency before an abortion. So I know that there are people who know the answer to that question, but and that might be Ginuity, it might be the folks at Plan C, it might be the folks at SAS. But again, no, I've heard of no contraindication with controlled substances, if that's what you're asking. And then Nikki Escott says, how can I, as a medical provider, navigate any mandatory reporting while being supportive and validating to any patients with substance use? I don't want to be or be seen as being punitive. We do have a fact sheet about CAPTA reporting. The first thing I will say is that medical providers are really going to be the front line, whether we're talking about drug use or abortion, about what role they will play in passing information on to government and law enforcement authorities. I don't know what state you're in. I do know that often doctors are told things at hospitals that this is the law, and it isn't necessarily the law. You need to check outside of your institution for what the law actually requires. Many states like New York and Massachusetts actually say report only where there's evidence that drug misuse is making somebody unable to parent, not just a positive drug test. If you're told that this is your hospital's policy or your institution's policy, ask to see that policy, because it turns out that often the policies don't say what the person telling you it says actually says. And then there are ways, if you actually must report, or even when you feel you must report, ways to minimize the harm that you're doing. And that includes things like making sure that when you're reporting, if you see any strengths of that person, you report all of the strengths as well. And explain, you probably need to do a little tutorial to whomever you're talking to, which is no drug exposure identifies a harm. And actually that could be a pretty impactful thing now that I think of it within the community of healthcare, child welfare people working in that field. In terms of, just to focus in a little bit, patients with substance use, the language we are so we have to use, substance use isn't a problem. I mean, you can't tell if somebody drinks alcohol, you don't know that they have cirrhosis of the liver. Use doesn't tell us very much at all. Yeah, and so if you're trying to build a relationship with your patient, the most important thing you can do is listen. You know, what does using this drug do for you? How does it help you? To ask questions that you might never have thought of, but come out of harm reduction therapy and out of just respect of, and I know you're often told you only have like 10 minutes to talk to your patients, but really just like, what if you were just curious, like, how does this work for you? And maybe there's something that would work better. Um, so I don't see any other questions. My question, I have another one for Dr. Bowers. I loved, Louise, when you said love is not a cure for substance use disorder. That was just like beautiful. And Dr. Bowers, I wonder if you could reflect on that in terms of what you saw happen to the women you were studying when their kids were taken away.
Absolutely. You know, many of these women had a very thin, if at all, support network. Um, and so, you know, we talked to them a lot about the history of drug use or a history of violence and other adverse childhood experiences that they may have had. And like 90% of these individuals reported that they had experienced some form of adverse childhood experience in their lives, which tells me that, you know, you're already predisposed to certain things. Like this, the odds are already stacked. So if you take a concentrated group of people who already have all of these issues and you add into that any other identities that they may hold, like being LGBT, experiencing domestic violence, substance use, any of those pieces added on top of an already stacked layer of challenges, you're going to see a lot of problems. You know, to Louise's point, many of these folks just simply threw their hands up, right? They had been working and working and working, trying to meet all of the mandate of their probation in cases where they were out on probation, and they could not, you know, couldn't find employment, could not, you know, get stable housing, could not obtain the basic things that you need to be able to live every day. You know, you've got to have shelter. You have to have some money coming in when you have children. And in a lot of cases, these were folks who had other children. So it may not have been that they lost custody of all of their children. They still had other children in the household. The child that may have tested positive for drug exposure was the child that was a part of the child welfare system, but then their case put their other children at risk, which added a whole nother layer. So, I mean, there were so many complex stories that were shared, but never, not one single time did I hear a person speak as though they did not love their children, that they did not have people in their lives that loved and cared for them, but their issues were so large, and they had so little resources and just even the knowledge of how to go about taking the first step in a lot of cases just wasn't there. And when dealing with Department of Children's Services, many times they were told you have to go and you have to find a provider to do your testing. You have to go and you have to find a person to do this piece of whatever requirement you had. So the caseworkers often weren't calling them back or weren't assisting them with meeting the mandates that they were given. So if you have a person, again, you have a person who already has all of these challenges and they're placed in a situation, there's just no way. There's no way they're gonna be successful. They were set up for failure from the start.
Thank you. So I have a question to both of you, I think. I loved, again, also Louise, you know, do you have a drug problem or a drug policy problem? And I just want to point out the intersections again. Prohibition doesn't work. So if you prohibit people from drinking alcohol, guess what? They drink alcohol. If you prohibit people from using drugs, guess what? They use drugs. If you prohibit people from having abortions, guess what? They have abortions. It was estimated that 200,000 to a million women had illegal abortions before Roe v. Wade. So, you know, if Roe is, you know, it is permitted to outlaw Roe and also punish the people who have them, um, it will be horrible and devastating. It already is to many people, but we also know it will not stop people from doing what they need to do. And the thing about prohibition is it's never enforced equally, right? It's not enforced against everybody. It is used as a, and people who put prohibition into place know it's not going to work. It's not going to stop women from having abortions. But what it does do is give cover for and an excuse to police certain communities and target certain communities. So prohibition is a way of using drugs to stop the organizing of the drug issue as a way during the Nixon administration of stopping and fighting Black civil rights protesters and anti-war protesters. And the focus on abortion now is a replacement for the direct attacks on those folks. But talking about what the world may look like as fewer and fewer people have access, particularly to abortion care, we know there are these safe medications, misoprostol and mifepristone. And there's a lot of discussion about like, how do we make sure people have access to them? And there are organizations, Plan C, SAS, and others that are educating about them. People have figured out how to get them. Some people have been arrested, not so many yet. But I'm wondering if you could talk a little bit about whether you see a connection, harm reduction activists, the work that you're doing, Louise, is also about getting people access to safe syringes and safe supplies relating to their drug use. I think it was Noemi Brain who called that illegal public health. We know that clean needles work. We know that other mechanisms make drug use safer. Do you see a similarity in terms of issues around access to mifepristone and misoprostol?
Absolutely. I mean, we're harm reductionists, so it's not just about drugs. It's about any harm causing behavior, anything that causes harm. We want to reduce that harm, right? So when we see people not able to get treatment for hepatitis C, we try to provide treatment for hepatitis C. When we see people not able to get access to so we work for sex worker rights. We understand that the criminalization of sex work creates harm, and so we fight that. So harm reduction is not just about substance use. It's about whatever laws that are creating harm for people. True harm reductionists get in there and they get busy. And absolutely, I believe we are absolutely the group to come to help to help to help reduce those harms. Um, we are fighting right now in the harm reduction space for issues around reproductive justice to be weighted as they should be, right? This was sort of a men's framing. Syringe service programs were created by men. They are heavily sort of functioning towards men's health. And now that we are seeing more women in the space, certainly uh, more discussion around gender and politics around all of this, that we want to make sure that the health of all people is important. And so we are talking about pregnant and parenting people, and trying to think about reducing harm to pregnant and parenting people as well. And I think this will grow as we see more team-based systems, more feminist models used to run programs, um, and really more women's led systems.
My response to the question is really, I mean, when you think about the nature of an unintended pregnancy, like that is a crisis in a person's life. And if we, stay true to what the principles of harm reduction are, it is meeting a person at their place of need. So for an individual who is experiencing an unintended pregnancy, that, whatever resources are available that we're able to connect them to as harm reductionists, should they're that's what RJ is all about. That's what harm reduction is all about at its core. It's about making sure people have access to the resources they need to self-actualize. So if If getting access to medication abortion is a tool towards doing that, then it is in alignment with harm reduction, in my opinion. I think that many folks who are doing harm reduction are providing safer sex kits. They are providing, emergency contraception in a lot of cases. And so to me, medication assisted abortion is no different. It is about educating people on how to use those medications safely, um, and creating a safety net of people around them so that when they do use them, they have support out there. So it is, for me, it is a harm reduction strategy.
Thank you. I'm not sure where we are on time, so if our host can let us know, that'd be great. Something else I wanted to ask you, Dr. Barrows, in the research, what was beautiful about the Sister Reach led research that looked at what happened as a result of the Tennessee law that was in place for 2 years. And I just want to say, you used the term sunset, which sort of sounds passive, and it happens every day. It went out of effect because of ongoing grassroots, state-based, and national efforts to get rid of it, and to keep it from being reenacted. So thank you for that. But what the research showed, what those interviews and focus groups talked about, is not only the people who were arrested as a result of the law, and that law passed in the guise of addressing drug use, opioid use, and its impacts, was also used to arrest a woman who attempted abortion with a coat hanger. I just want to clarify that. But it also talked about what it did to women who weren't arrested but were afraid they might be. So I wondered if you could just talk a little bit about that.
Absolutely. Yes, the biggest thing was, again, this perception of risk around, if I go to my doctor, if I go to community-based services, that they're going to report me, they're going to let someone know, and I'll be in trouble. And again, it was similar response. People avoided getting resources that they needed because they had so much fear around being criminalized or around losing their children. And so, again, but I do feel that, the convergence of those two communities, those two populations that we were speaking with, um, still, it still showed that this was an ineffective way to address the issue that they stated they were going to be trying to address. And to your point, many of those women, they were smoking marijuana. They may have been, doing any number of different drugs. It was not just opioids, but that because that law was in effect, all of these women were exposed to the risk of being criminalized.
So the word is that our session is over and the keynote for lunch has started. So I just want to say thank you, Justice Now, for giving us this opportunity. Thank you, my co-panelists. It's been such an honor to do this with you. So I look forward to ongoing work together, and we'll see each other sort of at the keynote.